No, it's great to be here. I have some old friends here. Jens and I have known each other for a long time. I couldn't remember how long I've known you. I think we've just always known. And then Dr. Abdul-Jabbar, we go way back from when you were a student. So I haven't forgotten. I'm pleased that you ended up in spine surgeries. Great to be here. So I don't remember how we came up with this topic, but I'll be talking today about the indications for interbody fusions in spine surgery. And this is actually one of my favorite things to ask the junior resident. Why are we doing this, putting this cage in? Because a lot of times when we get to the surgery, we just do it and we don't really think about why we're doing it. So I think it's really important that we do it with thoughtfulness and understand why we might think about doing this. So these are my disclosures. None of them really relevant to the topic at hand. So I think everybody in the audience understands that spine fusions are designed for stabilizing the spine by removing motion. And so the bone bridges the motion segments, so that segment doesn't move anymore. And the healing rate, or the bone healing to the bone, is improved by increasing the rigidity of the construct. So the fact that we can put screws and rods in there improves the likelihood of fusion. The type of instrumentation we use can improve the construct and the fusion rate. We all know that BMP is increasingly used to improve that fusion rate. And the other thing that improves the fusion rate is circumferential fusions. In other words, a fusion in the front of the spine as well as the back of the spine. And when I say the front of the spine, I mean between the vertebral bodies. The back of the spine is posteriorly over the posterior elements. And so kind of the way that I think of the reasons for combined surgery are sort of two buckets. The first bucket is if you have a patient that has a high risk for pseudoarthrosis. So if you don't think they're going to heal their fusion, there's really no point in just doing an operation that's not going to work. And this might be their prior history, like if they have a previous failed fusion, or if they have a medical history, if they take steroids, for example. They have osteoporosis, if they're on some of the rheumatoid medications that interfere with healing. One of the things that you probably don't see that much in the Pacific Northwest, and I don't see that much in California, but in Europe, smokers is actually a big thing. So we've had fellows in places that I've been where I would argue bitterly with the European surgeons, and I'm sorry I didn't get a chance to talk to Martin, and they almost routinely will do circumferential fusions because it's not socially acceptable to ask your patient to quit smoking. I don't do a fusion on a patient if they're still smoking, unless it's like an emergency, but I get a negative nicotine test before I book them for surgery. That's how adamant I am about fusion, the smoking history. In Europe, it's socially acceptable to smoke. It's obviously changing, but because of that, I think we agreed that that's why they do more circumferential fusions, because they have more smokers, and they can't ask the patient because it's kind of the norm there. You can have patients with anterior column deficiency that would have a harder time fusing, posterior column deficiency, and I'll show you that, and then a patient with a long fusion to the sacrum. So the first category, again, is higher risk for pseudoarthrosis, and the second bucket is if you want additional corrections. You want to loosen up the spine from the front to get more correction in either the sagittal or coronal planes, and I'll get into that. So this is a patient who has, you can see from the CT scan here, that the screws are loose here. You can see the haloing around those screws, and they've gotten loose. So they have a history of loose screws and a pseudoarthrosis, so they would be somebody that we'd want to do a circumferential fusion on. Deficient bone stock. So this is a patient who had a prior laminectomy for a tumor, okay? And so she had a tumor, developed scoliosis after that, but there's less bone there to heal too. And so it's less likely that she will go on to heal her fusion if we just did a posterior fusion. Now we could put in a lot of BMP, so that's another option. But another one option would be to do a circumferential fusion. And I think you can see from the back, this is a CT scan on a patient who has a broken rod in here that you can't see. That is a gap in her spine because she's been bent over for a long time with those bent rods. And you can just imagine, I don't care how strong the rods are, I can put 4 rods, 6 rods, BMP or whatever, that gap is always going to have some weakness and is not going to fuse. So that's a person that needs a cage and an interbody fusion. It's worth mentioning that there are some contraindications to an anterior approach, okay? We can't do this in everybody. So patients who have anterior scar is probably the biggest contraindication or difficulty getting there. So patients who have prior surgery, and you have to think about what their surgery is. So if you're going down to L5S1 and they've had a gallbladder surgery, that's pretty far away, so that probably won't cause any problem with scar tissue. But if you have a wide tumor resection, this is a patient who had a radical prostatectomy and radiation therapy. Guess what? My vascular surgeon said, no way, she can get anywhere. Okay. And then he's got ureteral stents. We did T-lifts on this one. Endometriosis tends to cause a lot of scar. So that's another one that might be a harder place to get there. So you need to be prepared. And particularly if you have a prior infection or abscess. So this is a patient who has a discitis. And I hope you can see from the back, but there's not a clear margin between the blood vessels and the scar tissue there. So you could possibly get around it. You might be limited on your approach, but you need to either be prepared or decide to do it some other approach. The ureteral stents can help you get around the scar tissue because you can identify the ureters, but that doesn't necessarily help you get around the blood vessels because tearing those clearly is not a fun day. Radiation obviously increases your likelihood of having more scar tissue. And the other potential contraindication is a patient who has a significant DVT risk. So a patient who's had a prior DVT, you know that when you go to anteriorly, we have to retract the vessels. And Chow's triangle tells us that stasis and not a and what's the other one? The not a clear flow are some of the risk factors. So the risk of DVT is much higher if you go anteriorly, and so those patients you might either want to avoid going anteriorly or think about being a cava umbrella to try to decrease the likelihood that any clot that forms doesn't travel to the lungs. So, and then again, so I'm going to show some examples of improving correction, including increasing your disc or pyramidal height, sagittal and coronal balance, and sometimes your shoulder rib prominence. So this is the old way of doing open anterior approaches. Who was around when we did these very large incisions from, oh yeah, that's why Jens and I go way back. So we used to do these operations I tell my residents now, from T10 to S1, and my patients would call them the shark bite. You do not want to be known as the surgeon that gives their patient a shark bite. That's like the opposite of minimally invasive surgery. We have these little Band-Aid incisions or whatever. So this is what they look like. You had a great approach. You can take discs out from T10 to the pelvis, but it's really obviously a morbid procedure from the standpoint of risk to the blood vessels, risk to the abdominal structures. Thankfully, God created a peritoneal sac to keep the internal organs away from spine surgeons, so we don't tend to get into the perineum. But staying retroperitoneal is obviously less invasive than transperitoneal. But there's other approaches, the lateral or oblique approach and posteriorly braced approaches, and we'll get to those. So the anterior approach has the advantage of having the most complete removal of the disc. And this is a more typical incision that you'd see nowadays, just approaching 1 or 2 levels from the front. It has the least risk to the neural elements because they're on the other side, okay? But it gives you probably the most correction of sagittal or even coronal deformity. You can really release widely, you can cut the ALL, which is oftentimes contracted and shortened, and you can get in 20 to 30 degree cages, either pre-made or custom made. The disadvantage, obviously, is that it's the most invasive option for these patients. Even though we don't actually cut muscles, particularly in an anterior approach where we just go along we go to a midline approach or a paramedian approach, and we actually retract the rectus to the side. So we're actually not cutting any muscles. But despite that, a lot of patients complain about abdominal muscle weakness, and I think just the traction on those muscles, especially for older patients, they never quite regain the tone that they have. So a lot of patients that complain about what they call their pooch. Okay, and you get some people that spend a lot of time not having a pooch. So if you don't warn them that they're going to have a pooch or they might have a pooch after surgery, they're like, well, my belly doesn't look right. My back pain is all gone, but my belly's still, they get very unhappy about these things. So going back to the earlier talk about setting expectations, it's important for them to understand that. And in this day and age, a lot of surgeons don't do a lot of anterior approaches on their own. So you may need a vascular surgeon or general surgeon for your approach. What do you guys do here? Do you have vascular or general surgery do the approaches? Yeah, we do. Yeah, I do that most of the time. One of my partners doesn't. And then I'll actually start the case if the vascular surgeon is off running around doing other cases just because I've done them in the past. So this is a patient. She's 48. She has osteoporosis, was treated on, I think, Forteo for a while. And you can see the scoliosis that she has there. And I chose, because of her sagittal imbalance and because of her risk of pseudoarthrosis and fusion to the pelvis, to do an ALIF at L3 to S1, including the one that was most tilted here, and a posterior spinal fusion that you can see there. So she did really well. She does have some proximal junctional kyphosis here, but went on to a solid fusion and did very nicely from that standpoint. This is another example, slightly older gentleman who had had a prior posterior spinal fusion with a TLIF a couple of years ago. And I think you can appreciate that he's really flat. He's got a really straight spine, okay? And hopefully most of you know that having a really flat spine is not a good thing, okay? You want to have an S-curve in your spine for sagittal balance. And so he was actually sent to me to do a pedicle subtraction osteotomy, which is a wedge cut out of the back of the spine, which causes a lot of bleeding. But we knew that he had an open disc space at L5S1 and a very worn out disc above there. So what we chose to do was an ALIF at L5S1, where again, we can restore a lot of that lordosis that we talked about, as well as get some lordosis at the proximal level above here. And we're able to give him a nice lordosis and restoration without doing a pedicle subtraction osteotomy. You can see the large cage here and the lots of distraction there at L5S1. And then we did the lordotic cage at the inner body level above here. So that leads us into lateral or oblique approaches. So this has been something that is no longer a new technique. It's probably been out there, 15 or 20 years now, and has the advantage of being less invasive and hopefully causing less pain. And the technique allows you to horizontalize the disc space. And it gives you, because of that, good sagittal correction in some cases, although the cages may be up to 30 degrees, but it doesn't correlate directly with the amount of correction you get, because you still have to, it depends on how you fill the disc space and how parallel your end plates are to your cage. But you have to, if you want to get full release, you have to release the anterolongitudinal ligament. And I don't know if you guys ever have the camera up when these surgeries are going on, but the ALL is right in front here, and what's right in front there? Some pretty important tubular structures. So if you don't see that directly, okay, and have to divide the anterolongitudinal ligament, you can end up in some big trouble. So you really need to know where you are. You really need to expose that fully before you release the ALL. But once you do that, you can really get nice correction, okay? So the disadvantage is that because it's a transpsoas approach, okay, you do have to retract the lumbar plexus, and particularly at L4-5, this can be problematic and result in some neuropathic pain for a period of time. You can't get to L5S1 through this approach because the blood vessels come directly across that pathway. You can still have some muscle weakness because of even from splitting the muscles from the side here. And there's, like a lot of these less invasive procedures, a lot of X-ray exposure to the team around. This is a patient who, she came to me with scoliosis, but her big complaint was spinal stenosis. She totally refused to let me address her scoliosis. She said, I've had this all my life. Don't fix my scoliosis, just fix my claudication. So I did a decompression and fusion, as you can see here. And over the next 8 years, she got more and more imbalanced this way. Okay, and you're all nodding because you're like, oh yeah, you should have done that. Like, she wouldn't let me. Anyway, so you can see how tilted she is. She's gone from being semi-balanced to 10 centimeters to the right. We actually worked up her neck. She had cervical myelopathy, which gave her some reason for imbalance. That got better for a while. Then she kept getting imbalanced. And I had to convince her that actually being imbalanced coronally is one of the reasons you can't walk straight, is because you're leaning so far. You just can't walk straight. It's not your myelopathy, it's your spine being good. And at this point in time, she really has very little pain, amazingly enough. So this is what she looks like from the side, and she's kind of tolerated the sagittal imbalance, but you look at, she's having a harder time righting herself, how she's holding her head up there. So again, her balance got better after her cervical spine surgery, but then it got worse again. She has minimal back pain. So 8 years after I do this lumbar decompression and fusion, I convinced her to have the surgery that I think most of us would have wanted to consider at the very beginning. You can see how far forward she is. And this was a challenge because her CT scan shows that she's fused at the levels above and below, and the ones just directly above, and the ones that are the biggest cause of her coronal imbalance. So I was prepared. I tried to come in from the side because, again, the lateral approach gives you a nice ability to horizontalize those discs. But I knew this would be a really hard one. There's a huge osteophyte there. So some of you when you've seen the X lifts, you know that it's hard to kind of dock on this. You keep falling off the osteophyte, and getting precisely in the right plane to cut across this is difficult. So I kind of gave myself a timing deadline. I said, if I can't get in there in I can't remember if it was 2 minutes or 5 minutes, I'm just going to abort and do it all from the back, or do the other one from the back. So I did the first one, the easier one here first, and then basically went through and was able to get a cage over here. And it's hard to see on this film, but you can see that if I propping that one open makes a huge difference from the standpoint of her coronal imbalance. And then we also were able to do inner bodies, which again improves her lordosis and her sagittal balance. So 6 months postoperatively, she's walking 2 miles a day. She only takes Tylenol by the time of her 6-week visit. She doesn't have pain, but again, she didn't have pain before surgery. And she tells me, my neighbors don't recognize me anymore because I'm standing straight again. So that was kind of, I don't think she realized how tilted she was. And these are the parameters you see here. Instead of being 10 centimeters to the right, she's only 5 centimeters, and we've improved all her other parameters. She spent so much time trying to rate herself that she's actually a little bit overcompensated now and leaning backwards to a certain extent. And I do have patients that do that. So another technique that I haven't really perfected yet, but one of my colleagues has, is the prone lateral, because switching positions obviously is time consuming for your surgery. And so you can do the lateral approach in the prone position. And this has the advantage of you can loosen the back up, and then you can put the cage in. The prone position helps you with the creating more lordosis, because if you extend the hips and put the patients on that Jackson frame where the belly sags, you can really create a lot of lordosis when you need to. So this is a patient that my colleague did, and you can see intraoperatively, they've got nice distraction across the disc space here, and then the cage is here. He's got a little bit of scoliosis, which is why this looks kind of off center there. So that's another approach which saves you, that has the same techniques but saves you at repositioning in the middle of the procedure. So I titled this talk specifically indications for inner body fusions, not for anterior and posterior surgery, for a reason, because the transforaminal lumbar inner body fusion or posterior lateral inner body fusion also can get you into the disc space and can help you recreate height. So the advantage, of course, is that it's the same incision as posterior, and you heard a little bit about the MIS option, although Dr. Solari, you didn't talk about TLIF very much. But you can decompress the nerve directly, you can look at it, or you can do it by raising or increasing the disc height. And there are patients whose disc spaces are so collapsed that if you just do a decompression posteriorly, the up-down stenosis will still be there, and that won't be corrected without doing an inner body or raising that foraminal height. The disadvantage, though, is the nerve is right there. So you can, if you're doing it from a PLIF or a TLIF approach, the direct way, you can sometimes need to retract the nerve. Although Dr. Solari showed from the MIS technique, which is a little bit more lateral than that, you can avoid that if you're careful. It has the least disc resection, though, because, again, you're working around the neural elements. And because you can't really cut the ALL or even loosen the ALL, you get the least amount of lordosis correction. So it's not really good if lordosis correction is part of your goal. So this is a patient she's in her 80s, she's Asian, and see a lot of Asians in here, a lot of Asian ladies in some other cultures, I'm sure, they get told, you're old, just accept what you are. Okay, and so they stop being able to walk a lot, they stop, whatever, and somebody says, you're old, just tolerate it. So when she came to me, okay, you can see she's got the severe foraminal stenosis here. I think you can see that the pedicle here and the pedicle there are so close together that just doing a decompression might not be enough to take care of her leg pain. And she actually started developing weakness in the time that I was seeing her. But she also has scoliosis. So when I started talking to her about fixing her scoliosis, I think I'm not sure if she totally ran in the other direction, but she was not interested. But her pain got worse, and then she started developing the weakness that I mentioned. And so what we kind of talked her into, I guess is probably the best way of saying it, is to just address her leg pain and that weakness with a short lumbar fusion addressing just her levels of stenosis that I showed you here. So we went ahead and did basically decompression and fusion with the cage on that concave side where everything was really collapsed. And this is what she looks like post-operatively. So she did really well. Her leg pain got better, but now she wants me to fix her scoliosis. So that's what happens when patients actually realize that it's not as bad and you don't have to do a huge operation right away. So I wanted to just give a brief mention of the minimally invasive interbody fusion. I have a colleague, Dr. Mock, who actually, so one of the countries that does a lot of MIS surgery and MIS fusions is actually Korea. And he happens to be Korean and speaks Korean. So he goes to Korea, speaks with the Korean doctors in person, and has learned that way. So learning curve, obviously he still has, but getting to learn directly from the people that have perfected it is a good way to do it. So Emma, you haven't talked that much about the lower infection rates and the less damage to the paraspinals, but clearly it's an advantage of MIS surgery. But there's a learning curve. And so this was a surgeon who basically looked at what he called his good to excellent success rate. It took him 72 cases to get there for MIS TLIF cases. So it takes a while. Okay, so we may be willing to put up with that, but we got to think about our patients who are in that learning curve and maybe not getting as good a result. Some patients like it. It's like, oh, Dr. So-and-so, this is the second time he's done it. It was all new, and I got to be one of those first people. So you just got to pick the right patients, but make sure the patients understand that you might not be at your prime just yet. I am too old to learn this technique, so that's why I have hired somebody to do this. So you end up with, for multiple levels, you end up with multiple incisions, but you can achieve good results for these patients once you've gotten through the learning curve. But TLIFs does not really improve lumbar lordosis. So you do get some improvement because you can position the patients prone, and that will maximize the lordosis. However, if you don't, because you can't resect the ALL, you can't really release the ALL. And some patients are so collapsed that their spinous processes actually kiss each other. And so I had a patient the other day that, and we see this all the time, where there's no room to create more lordosis unless you take out the interspinous ligament and pump some of the spinous processes. So you can see that the difference in lordosis improvement with ALIFs versus lateral approaches versus TLIF is really much more in favor of the ALIF approach. So combined surgery certainly can be useful. Typically for me, I'll do, for some of the bigger cases, I'll do ALIF at 4.5 and 5.1 because that's where most of our lordosis should be. And if they want or need more correction, I may do lateral interbodies. I don't tend to do TLIFs for my big deformity cases unless they have medical contraindications or don't need that much correction. And then they may get a T10 to the pelvis fusion for degen scoli or higher fusion if they have double major curves. There's certainly a trend for us to do less invasive surgeries, which less tissue dissection and less blood loss and less pain. And so this is a patient who had this prior surgery you see here. She did well for a number of years, but now she's developing this kind of thoracolumbar kyphosis above and has kind of a pretty well preserved disc space there. But she's old enough that I think she was in her 70s or so. And unfortunately, even if this looks healthy on an MRI, it's still a 60 or 70-year-old disc. So if we stop here, it doesn't tend to tolerate that well. So for older patients, I tend to include it just because I've seen a lot of examples where preserving a disc that looks okay on an MRI in an older patient doesn't last very long. So we did, you can see an anterior interbody cage here with, it's hard to see on this view, but we got a lot of height and lordosis, and we restored the height here across that kyphotic segment that you could see on our lateral view. And this is what she looks like post-operatively, standing nicely, got rid of that thoracolumbar kyphosis there, which was a lot of her symptoms. So combined surgery is less invasive than it used to be. We do get more correction now that we have posterior osteotomies and pedicle screw fixation, and we can do 3-column osteotomies. But we can, because of the way we do things, we do have a shorter hospital stay and less blood loss than we used to. And in selecting your inner body, you have to think about the surgical goals. Is it because you want to improve the fusion rate? Is it because you want to improve the correction? And this will start guiding which direction you're going to go as far as selecting your inner body cage. And certainly the surgeon's skills and familiarity is an important thing. You don't, you need to do something that you're comfortable with. And going back to your point earlier about, I think we all know the expression, if you just have a hammer, all the world's a nail. You have to have a lot of different hammers or different tools in your toolbox to know what the right thing or offer the best thing to your patient, or to have somebody that you can refer it to get other options. So the posteriorly based inner body fusions are less invasive, but result in less disc preparation and probably the least amount of correction for deformity. It's good for foraminal stenosis, and you can get about 5 degrees of correction if you could do a good job with positioning. The lateral approaches and oblique approaches are a little bit more invasive, but have more correction than posteriorly based approach. The ALIF is most invasive, but does give you the most correction. So depending on what your goals are and what your patient's goals are, these are important to keep in mind. So I think combined surgery likely achieves better correction in a lot of our patients and better fusion rates. You can try to compensate with BNP, but it might not always help you with the correction part. And again, part of it is assessing the goals for the surgery and your patient, and to optimize those the patient's pre-op and assess the risks of the additional incision. So thank you for your attention.
Serena, it's so good to have you here. Thank you for being here. May I be the first of all, thank you for being here and giving us your wisdom. Long overdue to have you at SSF. Thank you for having your beautiful daughter here, and she spent some time with us. So next generation in the wings. Let me ask you a very foundational question. The case of that aging Asian woman that you showed strikes me very near and dear to my heart. Are we doing way too many fusions? Are we just seeing everything through the lens of a fusion? This next generation here sitting behind us, they're all keen on robots and this and that cool technology and this implant and that bone growth medium, when frequently these patients actually just need a quality decompression, not some crude ripping out 30-minute procedure, but a quality decompression under motion preservation. Are we teaching the wrong emphasis in terms of hardware and fusion, which begets more fusion disease, as you showed in multiple other cases?
So I actually have another talk, which is that when you get away with a little operation for these patients with deformity, okay? Because I think you have to start with what's the smallest operation you can do for the patient for their symptoms. And most of the time it's just decompression. Okay, and I still do a lot of decompressions. They don't have as pretty x-rays, they're not the fun ones to show, and people don't ask me to talk about that, in all honesty. They ask you to talk about that or whatever, but they don't ask, but that's where I start, is what's the smallest thing that I can do for a patient? And then my next question is, how durable is that going to be? Going back to that foraminal stenosis, okay? So if the patient has bad up-down stenosis, I might say, well, this might not last, or we don't know, how much as your pain gets better when you sit down. But there's some people that really don't want a big operation, because then you're like, okay, they have a curve, and you fuse the one that has up-down stenosis, and the next thing you know, you've got this whole scoliosis operation in a 70-year-old who isn't symptomatic from their deformity. Okay, so I have a pretty involved talk with all these people saying, okay, well, I think this might last you 6 months, 2 years, or whatever, but you might need to come back. Okay, but there's such a big difference between a little decompression or two or a big scoli operation. A lot of them will choose to do the lesser the lesser decompression. And that's what I start with. That's the premise I start with, is what's the shortest thing to do. And there are some people that I will choose to do just a single level, knowing that there's a risk that in the rest of their curve, they might have worse. And again, this is part of my patient population. I get a lot of scoliosis patients. That's kind of the referral base I get. I have partners, Todd Alma, you know him well. He gets fewer deformity patients, so he doesn't have to think that much about or worry that much about that adjacent segment scoliosis. And so that's always the hard part. I had a patient just the other day that I was talking to about, so she has stenosis L3 to S1. She has enough scoliosis that we need to treat it, and it's really severe stenosis. But she's got really bad degeneration at the levels above that. So I'm like, God, do I stop and just do your decompression? You just do the L3 to the sacrum, or do I go up to L1? And this is part of like that expert opinion that I said, well, if we stop at L3, I think your risk of having adjacent segment disease within the next 5 years is probably 50-50. Okay, if I go to L1, because the levels above were pristine. If I go to L1, it's probably 20 or 30, so just giving him an idea, it's like, oh, let's go to L1. But that was her choice. Other patients were like, because I talked about the loss of mobility and this kind of thing. So I think you need to start from the least that will help them, and then think about the deformity and the consequences down the line. Because I'm always thinking about what's the next operation going to be. Because you probably get this here. If they've come to me before, nobody else out there is going to do their adjacent segment disease. They're going to come back to me. I have to deal with it. So I have to think in terms of kind of the preparation and the expectations. So that was a long-winded answer to your question.
I have so many questions always. May I ask one more? So the other question is there a cutoff for usual love deformity cases? Is there a cutoff by angles or something like that for scoliosis and decompression surgery? Is there something that you can use as a numeric guidance for us as surgeons to say, this is too much scoliosis, I'm not going to decompress you, only I'm going to give you a fusion?
A lot of it has to do with concavity versus convexity. So decompressions in the concavity, I think, are much more problematic than decompressions in the convexity, sort of by definition, because whatever is keeping that concavity from collapsing further, you're taking away part of it. Okay, so I'm much less likely to try to get away with the decompression only if the concavity is significant. Now, if it's only like 10 degrees, I might try to, whatever. But if it looks like they're verging on up-down stenosis and it's their concavity, then I probably will not try to get away with the decompression only. So it's more that part than the degrees.
May I ask a question from
a great presentation. I really learned a lot. As your career's been going on, do you see yourself relying more on PSOs, kind of bony correction versus more interbody fusions in order to regain alignment? And what's your thoughts on all of that?
The other way around. I think I went through a phase where I got very excited about these great 3-column osteotomies. You could do it all from the back. But there's a lot more blood loss. And so just because you're walking through that cancellous bone, and it's oftentimes a patient who's not that active or has prior instrumentation, so you have stress shielding, you know the patient population. So it's not trivial, and you can get up into a lot of. So in some ways, we're deciding, is a second doing an anterior approach or a lateral approach, is that more morbid, or is the blood loss more morbid? Okay, so that's kind of what you're deciding. And so in most cases, and I'm sorry, anesthesiologist had to leave, but in most cases, the blood loss is probably more morbid for the patient post-operative recovery. Having a lot of transfusions, between the pulmonary aspect, the fluid shifts and things like that, that makes a bigger difference from the standpoint of how risky and how difficult it is for them to recover from the surgery. So the downside of the anterior procedure, which I alluded to a little bit, is the DVT risk. And so I've started basically giving patients chemoprophylaxis a few days afterwards, and even in between procedures if I stage them, because that's the biggest risk that is really bad, obviously, and is potentially preventable. And I need to go back and look and see how much that's decreased it. But, kind of anecdotally, it seems like it's decreased it, but I have to look up the data.
What about filters? Some of our surgeons will have vascular help with access, and they'll put a filter in, before they even start, just to kind of prevent that. Do you see any role for that, or what's your thoughts on that?
I haven't routinely, unless I've had a patient that has actually had a DVT before, a non-provoked DVT before. Okay, because I'm provoking them again, obviously. I've got several vascular surgeons I work with regularly, and I don't know what the risk-benefit ratio is of putting in a filter and taking it out versus being on chemoprophylaxis for a few weeks. So I think that's kind of a math that you have to kind of calculate. But I have a feeling that chemoprophylaxis, if you just can start it late enough that you don't have a hematoma, an epidural hematoma, it's probably lower risk. But I don't know the actual data.
Great, thank you so much.
Thanks.
May I ask a question from Switzerland?
Obviously, older patients, scoliosis, etc. Would you mind elaborating more on what you do in terms of we also had to talk about optimizing patients for surgery in terms of any other studies you order, DEXA scans, if you put them on any form of bone building medications like Forteo or Tymlos, and when you employ cemented screws.
Okay, I have another whole talk on that. So one of the things I'd like to talk about is preventing complications, and a lot of it is optimization. And she actually talked a lot about those things. So I think it'd be nice to give any osteopenic patient something to build bone. But as you know, insurance won't cover it unless they're osteoporotic. So that's the downside. So I'll do a DEXA scan on any woman at risk, which is basically any perimenopausal woman, anyone who's had a Harrington rod. I look for reasons to get a DEXA scan because I think that's so important. And then the thing that we underappreciate is men. Okay, men over 70, they have a not insignificant risk of osteoporosis. And I can't tell you how many men that I found, it's like, oh, they never told me to worry about osteoporosis. It's just underappreciated, so it's the one thing that women get treated better on than men do is osteoporosis and osteopenia. So I'm always doing that. I ask a lot of questions about nutrition. She mentions there's not data on prehab. I believe in prehab. If a patient is telling me, well, how much do you walk? And they're like, oh, I just stay in bed because it hurts, or I just sit around because it hurts too much. It's like, you are going to walk. If you don't walk now, you're not going to walk after your surgery. And I actually make it a requirement. It's like, oh, you walk 5 days tomorrow, 5 minutes tomorrow. And then next week you walk 6 minutes or 10 minutes, whatever. And I bring them back and say, okay, how much do you walk now? And usually there's a family member that keeps them honest. And they don't want they actually don't like watching their family member sort of wither away. So they actually are good and supportive about this. So there's not great data, but I think it seems to help the patients. It helps them psychologically too. So I think optimizing is really important, and it's their physiologic age, the ones that are healthy, that that are active. Definitely the ones that seem to do better, and helping them get to the being active is a good thing. If you're, my pain, I have pain all the time. It's like, so if you walk, you still have pain. So isn't it better to walk and have pain? And they're like, they look at you like little puppies, like, poor me. It's like, sorry, it's going to hurt more after I do the surgery. You better do it now. So it's kind of a little bit of coaching. So thanks for that question. Anything else?
Any other questions?
Can you hear me? I would like to
All right.
ask a
Thank
question.
you very much, Dr. We're pretty much kind of at time, but if anybody needs to stretch their legs, we can always change in the scrubs after lunch, as we were going to do it now. But we have, is Morgan here?
She's next to him.
Welcome. So after Morgan's presentation, then we'll do we have a breakout session, and I'll explain how that's going to work after this presentation.
Morgan.